So 2 years ago, of course, we got the information that led to the approval of nivolumab, pembrolizumab, and then later atezolizumab for the second-line use in non-small cell lung cancer. But last year at ESMO, we heard about Keynote-24, which told us that for folks who have PD-L1 expression over 50%, pembrolizumab actually is superior to chemo, not just in terms of PFS, but also overall survival for that subset of patients. So that really has changed practice. It really makes it incumbent upon us to look for PD-L1 expression in all of our patients up front and to treat accordingly. So I think that's probably the most exciting thing that's happened in the last year. And now we really have opportunity for patients either to get PD-1 or PD-L1 therapy in the first line as appropriate, and then now for everybody else in the second line. To be determined. This is really an exciting area. And as I said, a couple years ago, we got second-line use, then we got first-line use single agent. But we still know that even as exciting as first-line pembrolizumab is, the response rates are still under 50%. How can we augment that? How can we help responders respond better and more durably? But also, how can we help the non-responders respond? As exciting as it is to have the second-line use, the response rates are still 15 to 20% in all comers. And so I think these combination studies, first of all, are coming fast and furious. There are literally dozens you can find on clinicaltrials.gov. The couple that are maturing the fastest, of course, are chemo and PD-1 combinations. And certainly at ESMO, we saw some updated information from a phase 2 trial that looked at carboplatin pemetrexed with or without pembrolizumab and really showed improved response rate in this randomized trial as well as prolonged PFS. There are phase 3 data coming, so obviously I think all of us want to see the more rigorous data before we make decisions about that. But this idea that maybe chemo and PD-1 inhibition may work together, something that maybe we wouldn't have thought about a few years ago, but certainly this kind of antigen release from cancer therapy may actually help. The other piece, of course, we're really excited about are IO-IO combinations. Certainly melanoma has led the way, and we know that using PD-1 or PD-L1 plus CTLA-4 inhibition really has been almost synergistic in that patient population. So now we're waiting very eagerly some of the phase 3 results to report out for either ipilimumab and nivolumab or tremelimumab and durvalumab, these combinations. Certainly at ASCO last year, we saw some very provocative data that PD-1 expression for PD-1 expression, there seemed to be a higher response rate when you added the CTLA-4. So I think we're very eager to see, again, the really rigorous phase 3 randomized data come through. And of course, both of these kind of issues of combinations raise even more the issue of toxicity. One drug has a certain amount of toxicity, but the compound toxicity really will be a problem. And as we start using some of these combinations, we really have to be very much looking out for these toxicities and again, engaging our multidisciplinary teams to manage those. So I think that's really kind of where we're going in the next year of data that unfolds. And aside from that, of course, there's the whole next generation. Those were the first to the table because chemo was on the table and ipilimumab was already being used in melanoma. All these other dozens of compound treatments are very exciting, but the question will be, how do we separate the wheat from the chaff? How do we assign patients and how do we follow through to make sure that we choose combinations that are sensical and that actually have efficacy?